Welcome back to the Ninja Nerd Podcast. Today we're talking about coagulopathy. We've got a few cases to go over. As always, when we present the case, the findings, the lab work, try and guess as we kind of work along, and hopefully you can learn a lot from this one.
Yeah, figure out why they're bleeding. That's the goal.
Yeah,
exactly.
That's a good thing to figure out.
Yep.
All right, so let's start off with case one. We have a 62-year-old male presenting with severe epistaxis and prolonged oozing at his IV site. The patient is hospitalized for a DVT and has been receiving IV heparin for the past 5 days. He denies prior coagulopathy or any bleeding disorders. For his exam, we have his vitals. BP is 125/80, heart rate is 90. Skin, as we said, he's oozing from his IV site, mild bruising over the extremities. For his abdomen, there's no hepatosplenomegaly. Extremities, no petechiae. We do some lab findings. We get the following back. His PT is normal. PTT is prolonged at 75 seconds. Platelets are normal. In a mixing study, we find that PTT normalizes after mixing. Alrighty then. Well, let's get into some questions.
That sounds good. Let's do it.
What does the abnormal PTT indicate, and why does it normalize with a mixing study?
That's a good question. I think before we talk about that, we have a patient here who comes in with some epistaxis and prolonged oozing at the IV site. So definitely some evidence of bleeding. And so the first thing I like to think about is it a platelet disorder or is it a coagulopathy? And so the CBC is usually pretty good. So if I were to get one, I always like to check that and just to make sure, because if the platelets are low, that could be a thrombocytopenia causing this. We didn't get that. Oh, actually we did. We got a part of our CBC, the platelets were normal. So that's always good. If the platelets are normal, then you can potentially consider platelet dysfunction, but usually you don't have abnormal PT or PTTs. So this is unlikely a platelet disorder. So then I come to the thought of, okay, this is probably, maybe at least to some degree, a coagulopathy. The finding of bruising over the extremities like ecchymosis also is more suggestive of coagulopathy as compared to a platelet disorder. So that's where the PT or there's an INR, which is the international normalized ratio. It kind of gives you a number of where most people fall on an average within a given area. And that basically measures your extrinsic pathway, so factor 3 and factor 7. Whereas the PTT monitors your intrinsic pathway, so factors 12, 11, 9, 8. And so those are really important in those pathways. And so when I see that the PT INR is normal, there's no abnormality in the extrinsic pathway, only the PTT is prolonged. So there's an abnormality in the intrinsic pathway. Question comes into this, which is it a factor deficiency or is it an acquired factor inhibitor or some type of factor inhibitor? The only way that you can determine that is to really do these mixing studies. And so if you add in plasma to this patient and they have a deficiency of some sort, usually the PTT will normalize. And so that tells me that there's a deficiency probably of some sort. And that's kind of important. So that's what I would start to think about right away is if the PTT normalizes, it basically, what it says is, I gave plasma that had all these different types of clotting proteins that you were deficient in. And if I give that back to you, you should clot if you were deficient in it. If you have like a factor inhibitor somewhere present in your bloodstream, then if you give the patient plasma, your plasma will still have those antibodies, which will keep attacking all those factors, and you won't be able to clot. And so that's the big difference here.
So I've heard that when you look at PTT, INR, I always thought PTT usually can be measuring for heparin, and then INR is usually measuring warfarin. Why is that?
Yeah, so whenever you give a patient heparin, that's kind of the big thing here. Heparin primarily affects the intrinsic pathway.
Okay, so it's really the pathway we're talking about.
Yeah, and so what it does is it basically enhances a molecule called antithrombin 3. And antithrombin 3 inhibits thrombin, but it also inhibits factor 9. And so if you go back to the intrinsic pathway, it's factors 12, 11, 9, 8. And so if I hit one of those, which I'm hitting thrombin, factor 9, and even a little bit of factor 11, I'm kind of hitting that intrinsic pathway. I'm not really involving the extrinsic pathway.
Right.
Warfarin is a fickle one. And the reason why is because it actually inhibits the production of factors 2, 7, 9, 10. So that's kind of weird. Because if you think about it, 7 is definitely a part of the extrinsic, and then 9 and 9 and is a part of the intrinsic pathway.
Sure.
So you would think, oh, that would affect both of it. It can. Problem is that when warfarin works, it actually causes a decrease in factor 7, and that has the shortest half-life. And so if you decrease the production of the one that has the shortest half-life, it'll break down, and you'll have lower levels of that as compared to the other factors like 2 and 9, 10. And so that's why it primarily affects PT-INR over the PTT, but it can actually prolong it in severe cases.
No, and I've heard that before, but I've never actually associated it to either of the pathways.
Yeah.
So that's super helpful.
Yep.
So next question, Zach, if we are suspecting then heparin coagulopathy, what would be the reversal agent for heparin coagulopathy?
Yeah, and so with this one, I wouldn't really need a mixing study to make, like, it was good to have it, but I wouldn't really need a mixing study. Honestly, the history of heparin use for the past 5 days, and then having now this new bleeding is enough for me to make the diagnosis, especially with a prolonged PTT and the use of heparin. So I wouldn't need the mixing study, but if I have a patient who's bleeding, they have epistaxis, they have prolonged bleeding from their IV sites, bruising over the extremities, that's enough for me to consider heparin reversal. You got to be really careful. I like to save heparin reversal for whenever a patient is really bleeding, like they're actually bleeding out, or they have an intracranial bleed. But if I were in the scenario to reverse it, I would give something like protamine sulfate, and that will basically block the effect of heparin and help to prevent that consistent bleeding. But I would hold off on giving it to this patient, but I would give it to a patient who was exsanguinating, losing a lot of blood. We needed to reverse that heparin, or it was a patient who had a intracranial bleed or a GI bleed of sorts.
With this patient, I know you said like the scenarios where you do give that protamine sulfate, at what point will the patient really, like, how would you tell he's transitioning where it's like, all right, he needs it now?
Usually, for me, if I had a patient with, like, let's say severe epistaxis and it was nonstop. Okay. So we tried other measures to be able to prevent, like, actually to stop or tamponade the bleeding, and they still wouldn't stop, I would probably give the heparin.
Okay.
Especially if it was severe, like, posterior epistaxis. Anterior epistaxis, probably not, but severe posterior epistaxis, I would consider definitely doing it if I couldn't stop it with other measures.
But for you, it's got to be bad enough in order to really give that reversal agent.
Yeah, I would like particularly anything that's causing, like, severe bleeding, so GI bleed, exsanguinating of some sort, or on top of that, they have a massive intracranial bleed, something of sort of that, or I'm not able to treat it with other normal supportive measures.
What's the real big complication then if you reverse this and things don't go according to plan?
Protamine can cause, so it actually can cause, like, allergic reactions. And so sometimes people can get, like, some weird reactions to it. And so I've seen a couple problems with it. It can cause, like, kind of an anaphylactic kind of presentation sometimes. So not my desired go-to, but when you need it, you have to use it.
Sure. Yeah. Makes sense. All right. Well, then that is the end of case 1. Let's move on to case 2. So again, like we've been doing as we go through the case, just try and guess it as we go along. So we have a 55-year-old female presenting with extensive bruising and a large right thigh hematoma after a minor fall. The patient denies personal or family history of bleeding disorders. She has a history of rheumatoid arthritis and is on methotrexate. We do an exam. Her vitals, BP is 120/75. Heart rate is 82. Skin, we notice extensive ecchymosis over the thighs, and like I said before, there's a large hematoma on the right thigh. There is no mucosal bleeding present. For lab findings, we get the following back. PT is normal. PTT is prolonged at 80 seconds. Mixing study, PTT remains prolonged after mixing. And then we have a Bethesda titer, high inhibitor titer. Lots of new things there going on here.
Yep.
Why does the PTT remain prolonged after mixing? And what does that mean, unlike the first patient?
Yeah, so it's the same concept. When you have a patient like this, we're going to assume that this is a coagulopathy. You can do that the ways that we talked about, which is, again, checking the CBC, checking to see if the platelets are normal or if they're low. But the other thing that's really characteristic more of coagulopathy as compared to platelet bleeding or platelet disorder-related bleeding is that platelets cause more like petechiae. They cause more mucosal bleeding, prolonged vaginal bleeding, things like that. Maybe they bleed a little bit after a cut. Whereas people with coagulopathies, they end up with like big hematomas or ecchymosis or hemarthrosis, like big swelling blood in the actual joint cavities. And then they really bleed a lot after surgery. And so those are kind of the big differences clinically between the two. But this one I'm definitely concerned about in a coagulopathy with the ecchymosis over the right thigh. The other thing that's really interesting here is that they have a history of RA, so rheumatoid arthritis. That can definitely create a autoantibody reaction. And sometimes autoantibodies can attack coagulation factors, especially factor VIII. That's the most common one. So factor VIII was a part of the intrinsic pathway, right? So it's always 12, 11, 9, 8. So if that's the case, 8 is a part of that intrinsic pathway, and I look and the PTT is prolonged. So it's probably some type of inhibitor that's binding to factor VIII, decreasing its ability to form the clotting cascade, lead to thrombin and fibrin, and trigger a clot. Only way to determine that is to do the mixing study. So you take the patient's plasma, they're going to have an inhibitor in their plasma. You give them normal plasma, which is supposed to have all the clotting proteins. So we don't know if this patient has an inhibitor or deficiency. If they had a deficiency and you give them normal plasma, it'll fix because you'll give them the things that they're deficient in. But if you give them plasma and it doesn't lead to clotting, that means that they have an antibody in there that's binding to all the factor VIII that you keep giving them. And so that's why it continues to remain prolonged and they bleed. So right there, that tells me that this is an acquired factor VIII inhibitor. And then the best thing you should always do is get a Bethesda titer. And if the titers are really, really high, you should definitely be considering putting this patient on like recombinant factor VII A, and that's usually what we like to do and consider immunosuppressive therapy as well.
Now, you mentioned the rheumatoid arthritis. Is this one of the big causes of a factor VIII deficiency?
Yeah, so on the exams, they love to do it.
Factor VIII inhibitor.
Yeah. So in the exams, you really look out for this in a patient who's postpartum. That's all. A lot of the times they do that in the exams. So really watch out for that one. Another one is autoimmune diseases, SLE, RA. Okay. Those are really, really big ones. Any kind of like solid organ malignancy is a big one. But in real life, hemophilia A, like treatments. So if a patient has hemophilia A, they have a deficiency of factor VIII. And so what do you give them if they have a deficiency? You give them factor VIII. That's a protein that may be foreign to the body in that sense. And so your immune system can create antibodies, especially if you keep getting a lot of treatments with factor VIII for hemophilia. So what I actually find to be more common in clinical reality is patients, if you do see them, hemophilia A patients who get frequent recombinant factor VIII treatments develop these factor VIII inhibitors.
All right. Well, I guess what we're all wondering now is how do we treat this condition?
Yeah, so usually for this one, you try and give them something to bypass. So the problem is the intrinsic pathway. And so if you give anything like factor VIII, it's just going to keep getting bound up by the antibodies. So you have to give the thing that goes the opposite pathway, the extrinsic pathway. So if I give factor VIIa, recombinant factor VIIa, that'll bypass that pathway and that'll take me down and lead to that thrombin formation. So that's what I like to do for that. Another thing is that you got to suppress these autoantibodies. So you'll never be able to really trigger that intrinsic pathway if you keep having antibodies binding to factor VIII. And so giving them immunosuppressive agents are going to be the best way to go about this. Steroids to really kind of like shut it down as quick as you can, and long term with things like rituximab are going to be alternatives. But that's the big thing, is really bypass the intrinsic pathway with recombinant factor VIIa. So you go extrinsic and then treat the underlying disease.
So you would always have to go extrinsic then. Do you ever get to a point where you're good with your intrinsic pathway?
Yeah, probably with the immunosuppression. So
Gotcha.
If you start really treating the underlying disease and you get rid of those factor inhibitors, then your factor VIII will actually start being able to be present and working and triggering that intrinsic pathway.
Gotcha. So like you said, just treat the underlying.
Yeah,
and you
but
should
in the
fix
interim, to kind of get the bleeding to stop, give them an alternative agent to go through another pathway.
Pretty cool.
It's pretty cool.
That's interesting stuff there.
Yeah.
Wow. All right, case 3. We have a 15-year-old male presenting with swelling and pain in his left knee after a soccer game. The patient has a history of recurrent hemarthroses and was treated with a factor VIII concentrate during previous episodes. For his exam, we note a swollen, tender left knee with decreased range of motion. He has no active mucosal bleeding. The PT is normal. PTT is prolonged at 85 seconds. And with his mixing study, PTT normalizes after mixing. So it kind of almost sounds a little bit like case 1 with the mixing study.
Yeah.
So some questions for you, Zach. What does the normalization of PTT with mixing indicate, like we talked before?
Yeah, so it's a factor deficiency. So anytime you have normalization, it means that you were deficient in a factor, and we gave you that factor back. So that definitely tells me that some kind of factor in the intrinsic pathway is deficient, whether that's again, factor 12, factor 11, factor 9, factor 8. One of those are deficient, and I got to figure out which one.
Confirming it's a factor deficiency. So how do you actually get to the underlying disease? Like what's truly going on here?
Yeah, so I'd want to figure out when I have a prolonged PTT and it normalizes with mixing, I have a factor deficiency, whether it's 12, 11, 9, 8. So the most common reasons that this would happen is factor 8 and factor 9 deficiencies. You don't see too many with factor 11. You don't really see too many with factor 12. So it usually comes down to a couple different things: hemophilia A, hemophilia B, and von Willebrand's disease, severe von Willebrand's disease. So I would check a couple different things. I would check a factor 8 level. I would check a factor 9 level. And I should actually say a factor 8 and factor 9 activity level. And then I would also check the von Willebrand antigen activity. And I would check what's called a aristocetin cofactor assay, which just determines the von Willebrand factor activity. And if I get all those things back, I would want to know, what does it give me? And so for this patient, let's say it came back with a decreased activity of factor 8. Well, and it came back with a normal von Willebrand antigen, a normal von Willebrand factor activity, a normal factor 9. That's hemophilia A.
And we also note in his HPI, he has been treated with factor 8 concentrate in the past.
Yeah, exactly. And so that's definitely a big thing to think about.
So with hemophilia A, I guess I'm wondering what the difference is between hemophilia A and B. Is it based upon age?
No, they're both X-linked. And so you'll primarily only see this really in males.
Okay.
But it's going to be a difference, particularly within the type of clotting factor that they're deficient in.
Okay.
So hemophilia A is a deficiency in factor 8, and hemophilia B is a deficiency in factor 9.
Okay.
Yeah.
Awesome. And then being in this patient, he had the deficiency with factor 8.
Yep, exactly.
Okay. Awesome. So then getting into treatment then, when do you treat with a DDAVP versus a factor 8 concentrate like this patient has already had in the past?
Yeah, DDAVP for hemophilia A is good and mild. So if they had very mild bleeding, like this, honestly, this would be a mild bleeding.
Right.
If I had severe bleeding, or they're getting ready to get a pretty big procedure, where they're at risk for bleeding a lot, that's when I'd give the concentrate. So I prefer to give the DDAVP if it's a small little tiny procedure, or if they have just a little bit of mild bleeding, not severe life-threatening bleeding, or they're getting a really big surgical procedure. So that's the big differences. DDAVP is great because it increases the activity of von Willebrand factor, which is only good if you're deficient in it or you have none of it. It's not good in type 2, which is a random factoid for people to know, but it's going to be good because it increases von Willebrand factor, so you can treat von Willebrand's disease. But the other thing about it is that von Willebrand factor actually kind of binds to factor 8 and kind of conserves the factor 8. And so it prevents it from getting broken down. So if I give DDAVP, I increase von Willebrand factor, which helps to protect factor 8 and keep the factor 8 levels a little bit normal.
Even regardless of this patient who doesn't have von Willebrand disease.
Yeah, you still treat it the same.
That's pretty cool.
Yeah, so if you're ever wrong and you're like, oh, I think it's von Willebrand's, or I think it's factor 8 deficiency, I mean, technically if you give them DDAVP, you'll be okay.
For the mild.
Yeah, for mild cases. Yep.
Which is perfect for this scenario.
Yeah, exactly. But if it was more severe, they had GI bleeding or brain bleed or something that was a little bit more concerning, or they're getting ready to get a big procedure, I would do the factor 8 concentrate instead.
Makes sense. How about, I have heard of one other one, it's the role of emicizumab. What is this, and how does this play a role with our patient here?
It's like an antibody. It's like a newer thing. It's prophylactic. So I'd say that you really just do this in patients who, let's say that you're giving them DDAVP, you're giving them factor 8 concentrates. They're refractory to a lot of these things. This is probably one that I would do, and I would also do this if their factor 8 activity is really, really, really low. I'm talking less than 1%, which means you almost have no activity.
Wow.
And so this is a really good one because this antibody can actually kind of act like factor 8. And so that's one of the benefits for this one. So I would really do the emicizumab in patients who have really, really low factor 8 activity level, or they have recurrent kind of episodes of bleeding. That's when I would consider this one.
And is that with or without symptoms?
What's that? Oh, this patient, I would say, yeah, with symptoms. If they have recurrent types of bleeding, so recurrent episodes, refractory therapy to DDAVP or factor VIII concentrate, or they have that activity level, regardless of symptoms, that the factor VIII activity level
is that low,
is less than 1%. It's like at that point, you got to give them something to prevent these events.
Okay. Well, then let's move on to case 4 now.
All right.
We have a 28-year-old female presenting with heavy menstrual bleeding and frequent nosebleeds since childhood. The patient reports prolonged bleeding after dental procedures. Her family history is notable for a maternal aunt with similar symptoms. For her exam, we have petechiae over the lower extremities and no hepatosplenomegaly. For lab findings, we get the following back. PT's normal, PTT's mildly prolonged at 42 seconds. For our mixing study, PTT normalizes, and we do a ristocetin cofactor activity, which is reduced. Now, you did mention before, Zach, sometimes if you note like petechiae and maybe some menstrual bleeding, maybe nosebleeds, you might be worried about something platelet related, right?
Yeah, exactly.
But let's just say in this patient, CBC platelets are good.
Yeah. So that's what's weird, right? So you would check it. Let's say that you did this, you got the, CBC, the platelets are normal, but the PT and the PTT show like an abnormality. Particularly in this one, the PTT is just a little bit prolonged. You still could have a coagulopathy, but there is a disease, especially the most severe form of von Willebrand's disease, like type 3, where you pretty much make no von Willebrand factor, but guess what else you don't make?
Factor VIII.
Factor VIII, yeah.
I'm getting good at this.
Yeah, exactly. So if the factor VIII is like deficient, you're going to affect the PTT, the intrinsic pathway. And so that's the kind of things that you can see. So this is a weird one where it's a platelet disorder, but it can actually kind of be categorized a little bit as a coagulopathy too.
That is kind of like a little misleading. Because if you get your lab studies back and it's like, wait a minute, like they're normal.
Yep. So this is one of those weird ones where if you did this one, you would see that they would have probably a mildly prolonged PTT. It's nothing insane, but it's due to that factor VIII level being deficient. It would be enough to be considered, this is technically a coagulopathy. And then from there, you would have to kind of go further. As we see here, they did the mixing study.
Right.
If it normalized, that means you had a deficiency, and it was in factor VIII. You gave them the plasma that had factor VIII, it normalized. The big difference here is, again, whenever I have a prolonged PTT, I think hemophilia A, hemophilia B, or severe von Willebrand's disease. The other thing is if I have a prolonged PTT is the heparin. Think about that one. If their heparin is even listed in the thing, it's that. Don't go down the rabbit hole of rare diseases of hemophilia A and B, etc. The other thing is the acquired factor inhibitor. So the big thing is if I see heparin use, it's heparin coagulopathy. If there's a factor inhibitor, it won't normalize. If it does normalize, it's hemophilia A, B, or von Willebrand's. I would check a factor VIII activity level. I would check a factor IX activity level to rule out hemophilia A and hemophilia B. But I would check a von Willebrand factor antigen and a von Willebrand factor level. And the only way that we really do the activity function is the ristocetin cofactor.
That was my next question, because we've talked about PTT, but I was like, that's a new one. I haven't seen that.
It's it's like a molecule that like binds to von Willebrand factor and GP1B, which helps the platelets to stick to one another. And so if you have no von Willebrand factor, you won't be able to bind the von Willebrand factor with the GP1B, and ristocetin is supposed to enhance that. And so if you have von Willebrand's disease and you have a deficiency in that von Willebrand factor, you have less clicking or connection between the GP1B and the von Willebrand factor. So it would be reduced. So that tells me that there is a deficiency potentially of von Willebrand factor. And that would tell me it's probably severe von Willebrand disease.
Just like our last patient, the comparison here, or when and when not to use it, DDAVP versus a von Willebrand factor concentrate. When do you use that?
Same thing like hemophilia A. Like if it's mild, very mild bleeding, like in this case, I'd probably go mild bleeding. I'd give DDAVP first. See, the other thing is von Willebrand factor concentrate. I'd give that if they had severe bleeding, GI bleeding, brain bleed, exsanguination of some weird situation, or they weren't responding to DDAVP, or they're getting ready to get a big surgery. So those are the reasons I would give that.
Awesome. Pretty straightforward. We knocked that one out of the park.
Yeah, that was good.
Let's go to case 5. We have a 70-year-old male presenting with generalized bruising and dark, tarry stools. Well, that doesn't sound good.
No.
Oh, okay. The patient has been on warfarin therapy for AFib. He missed his last INR check and recently developed bruising and gum bleeding. Over the past 2 days, he noticed dark stools consistent with melena. For our exam, we get vitals, BP's 120 over 80, heart rate's 90. Skin, we note the multiple ecchymoses, and his rectal exam is positive for melena. Lab findings, we get the following back. A PT INR, we have the INR is 5.8. PTT mildly prolonged and fibrinogen's normal. So my first question to you, Zach, is what causes the prolonged PT INR and PTT?
Yeah, so that means that both pathways to some degree are being kind of inhibited. Because again, PTT tells me that it's affecting the intrinsic pathway, and then PT INR tells me that this one's pretty high. So the INR is 5.8. So that tells me that the extrinsic pathway is much more affected. And so it kind of goes back where you hear warfarin. So if you hear heparin and you see PTT is prolonged, it's a smoking gun.
Right.
If you see INR, PT INR is really elevated and they're on warfarin, it's kind of a smoking gun as well. And so the interesting thing here is that I'd probably be good without having to do much else. If I see the use of warfarin and I see an elevated INR, that's pretty much a slam dunk for me. You could do something else, and we'll talk about that, but let's explain this real quick. So the PT-INR is elevated, and the reason why it's more elevated than the PTT is because, again, you kind of go back to what we talked about in the beginning, that warfarin inhibits the liver's production of factors 2, 7, 9, and 10. So 2 is thrombin, 7 is a part of the extrinsic pathway, 9, and then 9 is a part of the intrinsic pathway, and 10 is the common pathway. So really the big thing here is that the one with the shortest half-life is factor 7. So if you decrease the production of all of these factors, but the one that's going to get quickly reduced and it's going to get metabolized and excreted or lost from the body is going to be factor 7. So if you have a reduced production of all of these, that means that you'll have the quickest one, the one that'll actually drop the quickest is factor 7. So if that drops quickly, that hits the extrinsic pathway. So less factor 7 means you'll have less activity from the extrinsic pathway. And that means that the PT-INR will go up. If on top of that, factor 9, that affects the intrinsic pathway. That one has a little bit of a longer half-life, but it will be diminished. And so that's where you'll see a reduction in the PTT. I'm sorry, a prolonging of the PTT. Right. So that's the big difference here. So we see warfarin, it definitely affects both, but I would have more of an inclination to remember that it primarily prolongs the PT-INR more than the PTT due to the shorter half-life of factor 7.
What I'm curious about is how does vitamin K play a role within all of this?
So that's what I actually was going to say is another way that you could test, because DIC and liver disease can also cause this same thing. So fibrinogen would not usually be normal though in DIC. There is certain scenarios, but fibrinogen's usually pretty depleted in DIC, and it's also can be reduced in liver disease too. But so one of the things I like to do is if I see a prolonged PT-INR and maybe even a little bit of a prolonged PTT, I like to give vitamin K and just see what happens. If I don't have, like, let's say that there was no mention of warfarin in the vignette, and I didn't know if they had liver disease. I didn't know if they had some type of process here of DIC. If I gave vitamin K and their PT-INR improved, it tells me there's a vitamin K deficiency. So that's why I like to give vitamin K, because vitamin K deficiency is actually due to warfarin, because warfarin inhibits the vitamin K activity. Right. And so that's one of the big things here is I'd like to give vitamin K. If vitamin K causes improvement of the PT-INR, it's probably most likely vitamin K deficiency. If it does not improve the INR, it could be cirrhosis or really bad liver disease, or it could be DIC. And so that's one way that I like to tell patients, how are we going to try to figure out which one's the reason? We'll try vitamin K, give you a little injection of it, and see what happens to the PT-INR.
So you would just be administering vitamin K? Anything else?
If they were bleeding like a lot, so in this patient here, they had GI bleed.
I was going to say, it seems like he's bleeding pretty good.
So the thing about vitamin K is when you give IV vitamin K, it takes about 24 hours. So it's going to take a long time to kind of increase the production of factors 2, 7, 9, 10.
That's no good for him.
Yeah.
This guy's bleeding out.
Yeah, so I need something now. And so that's where prothrombin complex concentrate comes into play. And basically it's 4-factor PCC. Some people in the medical world call it K-Centra. It's 2, 7, 9, and 10. And so I'll give this PCC because it's going to quickly replace those factors that they're deficient in or being inhibited from that production.
So that's your bridge to vitamin K.
Yeah, exactly. So you give that, depending upon their weight, you give them a certain number of units, and then based upon that, I would also give them a 10 milligram intramuscular injection of vitamin K or IV vitamin K. And then from there, the IV vitamin K or IM vitamin K would start working on the liver while those prothrombic complex concentrate factors are kind of taking care of the coagulopathy in that moment.
So for our poor patient here, he does well. Let's say he does well. Everything works out great for him. But how do we prevent this in the future?
You got to be a little bit more careful with the warfarin. So it could have been a couple different things. It's hard to always tell. But when you're on warfarin, you got to be careful.
You can't miss your INR checks for one.
Yeah. And then there's a lot of things that can kind of affect the activity of warfarin too. And so it's really important to just make sure you're not missing that, especially, patients who have poor dietary intake. This can cause vitamin K deficiency. Malabsorption syndromes can cause vitamin K deficiency. And even antibiotics can cause vitamin K deficiency. So if you're on warfarin and you have any of those other things that happen, it can worsen the deficiency and it can actually cause worsening coagulopathy. But big thing is just to make sure that you're careful with the dosing of warfarin. So I'd probably hold this patient's warfarin, and then get that INR to kind of normalize for a little bit and then restart it.
Gotcha. Okay. We have one case left.
Let's do it.
All right. We have a 55-year-old female presenting with oozing from venipuncture sites, and she also presents with confusion.
Okay.
The patient was admitted for sepsis secondary to pneumonia. She developed diffuse bleeding and worsening confusion over the past 24 hours. For her exam, we have vitals, her BP is 90/60, heart rate is 110, and her skin we note petechiae, ecchymosis, and oozing from the IV sites. For her lab findings, we get the following back. PT's prolonged, PTT's prolonged. Platelets are 50,000, fibrinogen 70, D-dimer is elevated, and we do a peripheral blood smear and we note schistocytes. So what does this suggest, Zach? All of what I'm kind of presenting here, what's your go-to? What are you thinking?
Yeah, so again, you got a prolonged PT, PTT, so you got to think three things: vitamin K deficiency, DIC, and then cirrhosis. There's no mention of liver disease. I don't think that this could be vitamin K deficiency, and the reason why is vitamin K deficiency won't cause a drop in platelets, it won't cause a drop in fibrinogen, it won't cause this elevating D-dimer, and it definitely won't cause no dang schistocytes. So when I see schistocytes right off the get-go and I see thrombocytopenia and a low fibrinogen and an elevated D-dimer, it tells me that this patient probably has DIC. So DIC is basically, it's almost always usually due to sepsis or trauma or sometimes acute myelocytic leukemia, like the APL variant can do this, or placental abruptions, so obstetrical complications. But sepsis is a really big one. And what happens is you get this inflammatory cascade and it starts causing activation of procoagulants. And so they start clotting and clotting and clotting. And you get all these clots all over the body. And then because of that, you keep making these clots and consuming your clotting proteins. So you drop all of your clotting proteins. I'm not talking about 2, 7, 9, 10. I'm talking about everything from the extrinsic pathway, everything from the intrinsic pathway, everything from the common pathway gets depleted. And so that's why you see an effect on the PT and the PTT, because you prolong both of them because you're having deficiencies in both of the factors in those pathways. Fibrinogen is another protein which it's supposed to be utilized to make fibrin, and fibrin helps to form that platelet kind of like mesh to really anchor it down. And so if you're clotting a lot, you're going to be consuming a lot of fibrinogen. So fibrinogen levels will go down. And then the D-dimer is kind of just telling me that there's a lot of breakdown of fibrin, because that's usually what happens is you clot and then you break some of it down. So D-dimer is telling me there's a good kind of like clotting load right now. And then the last thing here is whenever you get these clots all over the place, when red blood cells and platelets run through it, they get consumed. The platelets get consumed to make more clots, and the red blood cells get ripped to freck. Right? And so the red blood cells, when they get ripped up, it makes schistocytes. And then the platelets dropping is because they keep getting consumed to make more and more clots. So that's really a telltale sign for me. I would say that would be enough for me to determine DIC. If you really wanted to, you can check a factor VIII level if you're ever confused. DIC and liver disease are kind of tough, but factor VIII is made by endothelial cells. It's not made by the liver. So it's the only clotting protein that's made by, again, the actual endothelial cells and not by the liver. So if a patient has severe liver disease, it wouldn't affect factor VIII. So they would have like normal factor VIII levels, whereas DIC, every clotting protein is affected. So factor VIII levels would be low. So that's something you could always consider, is check a factor VIII level if you ever are tough to determine between DIC and like full-on liver failure.
So in our patient, we pretty much have determined DIC most likely from her sepsis.
Yeah.
How do you treat that?
It's usually supportive. I mean, it's a tough disease, and so obviously treating the underlying cause will help to prevent the continued inflammatory response. So I treat with antibiotics, vasopressors, fluids as needed. But the biggest thing is to try and stop some of the bleeding, right? So I would say the first thing I would do is you can kind of look at the PTT, and I would say we could give some FFP.
Okay.
So I like FFP for DIC because it contains all clotting factors, and patients who have DIC are deficient in all clotting factors. And so I'd give a little bit of FFP and see if that helps to bring the PTT and the PT down and help to kind of prevent some of the bleeding. Platelets, I would only give platelets if it's less than 50,000 and they have severe bleeding, or they have some kind of pretty good bleeding. It's not less than 50,000. I know it's like really, really close, but I wouldn't give the platelets unless it's less than 50,000 and they were having some pretty bad bleeding.
Okay.
The other reason is you can give it less than 10,000 and no bleeding.
Yep.
So I wouldn't give any platelets. And then the fibrinogen is low. So if you give FFP, it does have fibrinogen. So I'd try that first, see if it brings the PTT and the PT down, and see if it brings the fibrinogen up. But if the fibrinogen is still less than 100 after the FFP, I would give something called cryoprecipitate. And then I would also check a CBC, look to see what the red blood cells are. Usually if the red blood cells are really, really low, we could consider a packed red cell infusion, but it's really just trying to treat the underlying disease, and the best way to treat the coagulopathy is to give them all clotting factors, FFP. And then if they're still deficient in fibrinogen, after that, cryo if their platelets are less than 50, and then they're bleeding, platelets are less than 10,000, no bleeding, platelets.
Okay. Well, that was case 6, and that was all of the cases we have here for coagulopathy.
Yeah, that was a good one, man.
That was good. It was a lot of information, but it seemed pretty straightforward with how you kind of approach it.
Yeah, and I think that's the key thing, is just always having like a systematic approach, and you kind of got it as you went through it, right? That it's always you check the CBC, you look at the platelets. Is the platelets low? Oh, they are. Maybe it's a thrombocytopenia. Go down that podcast that we talked about, right? If the platelets are normal, but then you have a normal PTT, it's a platelet disorder. So then you got to go down the other arm of the platelet disorder podcast that we talked about. But if the platelets are normal and you have abnormal PT and PTT, then you got to go down the line and say, okay, abnormal PTT, that's intrinsic factor. Okay, are they on heparin? All right, cool. All right. Then from there, do the mixing study. Does it normalize? Oh, it does. It's deficiencies. Hemophilia A, B, von Willebrand. Oh, it doesn't normalize? Factor VIII inhibitors. Oh, they have a prolonged PT and maybe even a PTT. Okay, could it be vitamin K deficiency, DIC? Could it be cirrhosis? How do I really tell? Best thing to do, give them vitamin K. See if they improve. If they do, it's a vitamin K deficiency. All right. And if they don't, could be DIC, could be cirrhosis. How do you really determine the differences in those? Again, you would see schistocytes with DIC, you'd see thrombocytopenia, you'd see a decreased fibrinogen, you'd see an increased D-dimer. But then the big thing, a kind of little pearl there, is the factor VIII level will be low in DIC, but it'll be normal in liver disease. So those are the different ways to think about this, and I think if you get that approach, it becomes a little bit easier.
Well, we definitely hope these podcasts are helping, because we love making them. They've been a lot of fun, and we're just going to keep doing them. We're going to keep going through topic after topic, really giving you tons and tons of cases, and hopefully you can keep solving things and really working through them and just acing all your exams.
Yeah, that's the best, man. So, engineers, thank you so much for hanging around. Thank you for listening to this podcast, and I hope you guys really enjoyed it. And as always, love you. Thank you. Until next time.